Welcome to Quick Medical Review, the podcast where we make complex medical topics simple, high yield, and exam ready. Today we're covering cystic fibrosis, the most common life-limiting autosomal recessive condition in Caucasians, and a heavily tested topic across USMLE, MRCP, PLAB, and SMLE. Let's get into it. Cystic fibrosis, or CF, is caused by mutations in the CFTR gene on chromosome 7. This gene encodes the cystic fibrosis transmembrane conductance regulator, a chloride channel found on epithelial cell surfaces. The most common mutation is the F508del or delta, F508, which accounts for approximately 70% of CF alleles worldwide. Being autosomal recessive, both copies of the gene must be defective for the disease to manifest. Carrier frequency in Caucasian populations is approximately 1 in 25. The defective CFTR channel leads to impaired chloride and water secretion across epithelial surfaces, producing thick, viscous secretions that obstruct airways, pancreatic ducts, bile ducts, and the vas deferens. Newborn screening is performed via the heel prick blood spot test measuring immunoreactive trypsinogen or IRT. Elevated IRT triggers genetic testing for CFTR mutations. The gold standard confirmatory test is the sweat test measuring chloride concentration in sweat. A chloride level above 60 millimoles per liter on 2 separate occasions is diagnostic. Levels between 30 and 59 are borderline and require further investigation. CF is a multisystem disease. The main systems affected are respiratory, gastrointestinal, and reproductive. Respiratory thick airway secretions cause chronic cough, recurrent chest infections, and progressive bronchiectasis. The most common early colonizing organism is Staphylococcus aureus. Pseudomonas aeruginosa becomes the predominant pathogen with increasing age and is associated with disease progression. Burkholderia cepacia complex is a significant concern because it is transmissible between CF patients and associated with rapid decline. Gastrointestinal pancreatic insufficiency affects approximately 85% of patients, leading to malabsorption, steatorrhea, fatty stools, and failure to thrive. Meconium ileus is the presenting feature in approximately 15 to 20% of neonates with CF and should always raise suspicion. CF-related diabetes develops in up to 50% of adults due to progressive pancreatic damage. CF-related liver disease with biliary cirrhosis can also occur. Reproductive: almost all males with CF are infertile due to congenital bilateral absence of the vas deferens or CBAVD. Female fertility is reduced but not absent due to thick cervical mucus. Other features include nasal polyps, rectal prolapse in children, and distal intestinal obstruction syndrome or DIOS in older patients. Management is multidisciplinary and lifelong. Airway clearance, daily physiotherapy with chest percussion, active cycle breathing techniques, and exercise. This is the cornerstone of respiratory management. Mucolytics: inhaled Dornase alpha, also called DNase, breaks down DNA in mucus and improves lung function. Inhaled hypertonic saline also aids mucus clearance. Antibiotics: prophylactic oral flucloxacillin against Staphylococcus aureus from diagnosis. Pseudomonas colonization is treated aggressively with nebulized tobramycin or colistin for eradication. Acute exacerbations may require IV antibiotics. Pancreatic enzyme replacement therapy, PERT, taken with every meal and snack to aid digestion and absorption. Patients require a high-calorie, high-fat diet to maintain adequate nutrition. Fat-soluble vitamin supplementation, vitamins A, D, E, and K, is essential due to malabsorption. CFTR modulators: these are the most significant therapeutic advance in CF history. Elexacaftor, tezacaftor, ivacaftor, marketed as Trikafta, is now standard of care for patients aged 2 and above with at least one F508del mutation, covering approximately 90% of CF patients. This triple combination has shown dramatic improvements in lung function, nutritional status, and quality of life. Lung transplantation is considered for end-stage lung disease with an FEV1 below 30% predicted. Rapid-fire summary: inheritance: autosomal recessive. Gene: CFTR on chromosome 7. Most common mutation: F508del. Diagnostic test: sweat test, chloride above 60 is diagnostic. Newborn screening: immunoreactive trypsinogen. Respiratory organisms: Staph aureus early, Pseudomonas later. Neonatal presentation: Meconium ileus. Pancreatic insufficiency, steatorrhea, failure to thrive, treat with PERT. Male infertility: congenital bilateral absence of the vas deferens. CF-related diabetes, up to 50% of adults. Mucolytic inhaled dornase alpha. CFTR modulator. Elexacaftor, tezacaftor, ivacaftor, Trikafta game-changing therapy. Vitamins, supplement fat-soluble vitamins A, D, E, K. Lung transplant for end-stage disease. That's your complete review of cystic fibrosis. Study smart, not hard. If you found this episode useful, subscribe, leave a review, and share it with your study group. This has been Quick Medical Review. See you in the next episode.